Hi, I am Dr. Amit Mishra. I am professor in pediatric cardiac surgery here at UNMICRC Institute of Cardiology and Research Center. Today we are discussing a very important topic, tetralogy of fellow. We will be discussing it in the two parts because it is a very long topic and somehow it is very difficult to understand also. So, the first part we will be discussing mainly the morphology in tetralogy and how exactly the developmental of the septum and the pulmonary stenosis occurs. I will try to keep it very simple. This is a cyanotic congenital heart disease which is very commonly seen in our day to day practice, and it is also very difficult to take a decision initially what kind of surgery which patient is required, because there is no standard guideline and every patient there is a different indication for different surgery. So, basically these are conotruncal anomaly. This conotruncal, this is the portion cone and the truncus. This is the anomaly of the conotruncal, and normally the conotruncal rotates anti-clockwise during the development, whereas in tetralogy there is a clockwise rotation. This we are listening from our first year MBBS days that the anterior and the cephalic rotation, anterior and the leftward rotation of the infundibular septum is the key factor which causes all the problems in tetralogy. So, now we will try to understand what does exactly it does mean. It just confuse anteriorly and cephalic movement of the infundibular septum. It is difficult to understand, people do not understand, and I believe one should make the things as simple as possible so that everyone can understand, as the Einstein also said the same. So, now let us see, this is the anatomy of a normal interventricular septum, aorta, pulmonary artery. This is a trabeculoseptum marginalis, muscular outlet, infundibular septum, this is membranous septum. Now, what happens in tetralogy, that this infundibular septum decides to move anteriorly and leftward direction. So, what it is here, it is moving anteriorly, it comes anteriorly and towards the leftward. So, as a consequence of this comes right in front of the pulmonary artery. So, it is going to obstruct the pulmonary blood flow. It is not only moving all alone, when it is moving, it tries to move the aorta also with it. This is the ventricular infundibular fold where it is actually attached, and now when it moves anteriorly and leftward, try to pull the aorta also with it for some distance and then it leaves it. So, the aorta also now comes to the right ventricular cavity. This is the explanation of the same thing in a short axis view. Here this is the infundibular septum, here is the infundibular septum, and it is moving anteriorly and leftwards. As a consequence to this, it is causing right ventricular outflow tract obstruction, same thing in a short axis. So, I hope you understand now how this infundibular septum is moving anteriorly and leftward. And if you see, as a consequence to this, the aorta also moved into the right ventricular cavity. So, these are few phases of tetralogy where there is a mild pulmonary stenosis, moderate and severe. Depending how much the septum has moved, how much the aorta is extroverted, it causes that severity of the obstruction, and it also consequent to is there is a severity of the symptom also. Mild tetralogy, you call it the pink tetralogy, moderate there is mild cyanosis, and severe form of tetralogy when there is a severe cyanosis is there. Now, this is a morphological specimen, exactly the same thing. This picture depicts something different, and this is the morphological specimen, because actually what we see is this. This is simple to explain, but what actually we see during operation is this. This is trabeculoseptum marginalis, anterior limb, and this is the posterior limb. Here also this is trabeculoseptum marginalis, anterior limb and the posterior limb, and this is muscular outlet or the infundibular septum which is moved anteriorly and the leftward. Here it is connected to ventriculo-infundibular fold. This is ventriculo-infundibular fold. This is ventricular fold. Here you see this is the ventriculo-infundibular fold. This is anterior leaf and junction of the anterior and the septal leaflet of the tricuspid valve, and here it comes the posterior limb of the ventriculo-infundibular fold. So, these are the few margins of the VSD which one should always remember, and sometimes these are asked in the exam how the margins of the VSD is formed in tetralogy of fellow. Now, basically if you try to understand this, I try to make it as simple as possible. One can understand the anatomy of the septum. If you understand the anatomy of the septum and the cephalic movement of the infundibular septum, one should be able to understand the tetralogy. Now, try to understand these few figures. It is your right hand and this shows trabeculoseptomarginalis. It is basically depicting the septum. Above the hand it is right ventricle and below the hand it is left ventricle. This one is the anterior limb of trabeculoseptomarginalis, other is the posterior limb of the trabeculoseptomarginalis. I am trying to simplify so that one can understand it easily. Now, exactly the same, here you can see the left ventricle, above is the right ventricle, anterior limb and the posterior limb of the trabeculoseptomarginalis can be clearly seen here. Same hand which is moved just to show the left ventricle. Now, I am trying to show the infundibular septum, how the infundibular septum is normally attached. Normally, this is trabeculoseptomarginalis, this is infundibular septum, this is membranous area, here you see the parietal band and this is the infundibular septum. Now, this infundibular septum is going to move anteriorly and leftward. Try and understand, this infundibular septum is going to move anteriorly and in the leftward direction. So, how the margins of the VSD are going to be? So, basically there are two kinds of VSD which we see, large malaligned VSD, either it is perimembranous or doubly committed, usually both are large malaligned VSD. Right coronary cusp usually overhangs the VSD with a part of the aorta is into the right ventricle, whereas the posterior superior angle is the higher up. Now, see this, as I earlier told, this infundibular septum which was attached here with the trabeculoseptomarginalis is now moved anteriorly and the leftward. So, because as a consequence to its movement, first of all this will move towards the pulmonary artery, towards the left shoulder. It is going to move towards the pulmonary artery anteriorly and cephalic direction. So, it is going to obstruct the pulmonary artery. This chunk, this tissue which was actually into the septum has moved leftward and anteriorly. So, this is causing obstruction. Mind well, we will be discussing in the next class that this tissue need to be excised, because this is the tissue which is going to cause the obstruction. The structure which is causing the obstruction has to be excised to achieve the RVOT reconstruction in tetralogy surgery. So, now this is a VSD, it is malaligned, you are saying in 2-dimensional plane, otherwise it is in 3-dimensional plane. This is the posterior limb of trabeculoseptomarginalis, anterior limb of the trabeculoseptomarginalis, infundibular septum which has been moved anteriorly and leftward, ventriculo-infundibular fold. Behind this is a aortic valve. If you see practically below this, there will be an aortic valve. This is tricuspid valve and again this is the posterior limb, and somewhere here we see the muscle of Cvts. Now, sometimes we see doubly committed, that was perimembranous VSD and this is doubly committed VSD. Here same trabeculoseptomarginalis where the anterior limb is directly connected to the pulmonary valve. So, you will just below the pulmonary valve you will see large VSD. Then this is the direct pulmonary valve is directly connected to the ventricular-infundibular fold, and then ventricular-infundibular fold there is a muscle ventricular-infundibular fold between the tricuspid valve and the posterior limb. So, ventricular-infundibular fold directly connected to the posterior limb of trabeculoseptomarginalis. One good thing about this VSD is because below the tricuspid valve there is a muscle, these two muscles which are in continuation. So, the conduction bundle is not here. So, technically speaking, these VSDs are very easy to close if you are closing from RVOT. If you are closing from RA, they are difficult because this portion is not very easily visible and you are free from conduction bundle. So, you will not get the heart block in this type of VSD. So, this was doubly committed VSD in tetralogy. Now, just to know about the margin, posterior superiorly ventricular-infundibular fold, aortic annulus and part of the aortic annulus which is adjacent to the non-coronary cusp, posteriorly base and anteroseptal commissure, and variation of the membranous flap, the part of the membranous septum. Inferiorly, there are two limbs of trabeculoseptomarginalis. Somewhere you will see the muscle of Cvts and continuation of the right posterior division to the trabeculoseptomarginalis. This continues here like this. Anteriorly, the anterior division which continues and becomes the infundibular septum. Sometimes the conal septum is absent, that is what we discussed, we call it as a doubly committed VSD, and in 8 to 10% patients we get additional muscular VSD is also possible, which has disastrous complications if it is there and it is not known at the time of diagnosis. So, one should try and remember this is a very simple diagram which will tell you the margins of the VSD, when and where and how you can get a heart block and how it can be avoided. That we will be discussing in our surgical lecture. Now, again this is the same morphological picture. This septum, which was actually the infundibular septum, has moved and it has come here. There is a thick fibrosis which we call as the os infundibulum, and this is the area which need to be resected. This VSD has to be closed. It is a large malaligned VSD, and this is the area which is actually it was the infundibular septum moved anteriorly and leftward. So, we have to resect this, so that now you can see the os. If you resect this, you will be able to see the pulmonary valve through from here tricuspid valve, you will be able to see the pulmonary valve through tricuspid valve. If you resect this area which is coming in your way, it is infundibular septum, then you will be able to see the tricuspid valve. I am again and again telling, because this is the principle of this subject, you need to resect properly the part of the infundibular septum which is moved, and then you have to close this VSD. I hope you people are understanding, because this is the crux, the movement of the infundibular septum is the crux of tetralogy. You understand this movement, you understand this resection, then you will understand it. It is not that difficult a topic. Then we will be discussing some important aspects like right ventricle, left ventricle arch, conduction system, aorta, ductus and all other things. These are all the morphology which one should know. Then infundibular septum is displayed anteriorly, we have already knows os infundibulum. It may be higher up, it may be lower, and sometimes there is a acquired pulmonary atresia. Acquired pulmonary atresia is usually seen in the post shunt patients. So, infundibulum usually it is like this, it is normally open from tricuspid, you can directly see the pulmonary valve easily. If you see normal VSD or ASD, you will be very clearly you will be see the pulmonary valve. But whereas in tetralogy there is a persistence of the conal septum which comes down. So, the length of the infundibular septum increases, but it is not always true. There may be very short infundibulum, there may be very long tubular infundibulum, there may be severe pulmonary valvular stenosis, or there may be tubular stenosis. So, sometimes the stenosis is quite lower down. So, we call it as a third ventricle also. Now, pulmonary valve, almost in 70 to 75% patient it is stenosis. 2/3 of the patient may have a bicuspid pulmonary valve. Valve area is always less compared to the normal pulmonary valve area. It may be thickened, vestigial. Sometimes you may get a normal pulmonary valve also, but the area of the pulmonary valve will always be less. Now, this is a typical stenotic tricuspid valve, severely thickened stenotic valve of the tetralogy. On all these are commissure. So, one has to release all this. This is a typical chronic tetralogy having severe pulmonary stenosis, and this is how it looks like. So, you have to release all the tethering to the adjacent wall of the pulmonary artery, and you have to cut this commissure to make the valve free, thin, free, pliable, which can be used without its replacement and just by putting transannular patch or without transannular patch. But if the transannular patch is not used, usually these valve will re-stenosed. Now, this is again the same thing, it is a longitudinal incision on the pulmonary artery and the showing pulmonary valvotomy. Now, right ventricle, because there is a clockwise movement. So, right ventricle moves in a clockwise direction. So, you will see the right ventricle is lying anteriorly, left ventricle goes more posteriorly. There will be a transverse depression. One can understand, if you have done quite a few tetralogy, you will be able to understand from outside that where exactly the depression is and where exactly the side of main obstruction. Sometimes when the coronary artery is crossing right ventricular outflow tract, then this judgment becomes very important, whether the patient will need a conduit or you can do the resection from inside and from the pulmonary artery. So, this depression will exactly tell you where exactly the obstruction are there in the right ventricle. Right ventricle thickness is same as the left ventricle. Right ventricular end diastolic volume and ejection fraction is less usually in tetralogy patients, and that is the cause that the post-operatively they develop the right ventricular dysfunction commonly seen in the majority of the tetralogy. Now, left ventricle wall thickness is normal. Left ventricle end diastolic volume either normal or low. Rarely it is less than 30 ml per meter square. So, rarely you will see the mitral valve is small or the left ventricle size is small, and the management is different. One has to go for the shunt to increase or improve the left ventricular end diastolic volume, and then you can go for the corrective operation. Though it is very rare, but one should always consider for the left sided structure, how is the anatomy and the function in tetralogy, because these things you will realize after the surgery. Now, this is one of the operative photographs showing aorta, and here is the pulmonary artery, and one can see the left anterior descending artery is crossing, arising from the right coronary artery, and it is crossing the right ventricular outflow tract. So, here these usually 5% of the patient of tetralogy will have this problem when the major coronary artery or the left anterior descending artery is crossing the RVOT. And then in these patients, one has to, this patient, it is very clear, is at the level of annulus. This patient will definitely need a conduit, but sometimes it is crossing lower down, and then it becomes very important to have a judgment where exactly the obstruction is there, whether you can get away without the conduit, you can put up RVOT patch or the main pulmonary artery patch. But this patient, it is very clear that this patient is going to need the conduit. Now, again, this is the CT image. You can find out whether the anterior descending artery is crossing or not crossing. One can tell it on the echo, and if there is any doubt, one can get a CT, and the CT scan will tell you that the major coronary artery is crossing the right ventricular outflow tract. In fact, this is the left anterior descending artery which is arising from the right coronary artery and crossing the RVOT. Now, one of the very important part of the tetralogy is cyanotic spell. If you ask in exam, most of the people, either they won't be able to tell what exactly is spell, or they will not be able to tell how the spell has to be managed. So, a brief about the cyanotic spell. This is progressive increase in rate and depth of respiration followed by paroxysmal hyperapnea, increased cyanosis, limpness, syncope. Occasionally patient may get convulsion, cerebrovascular accidents, and sometimes there is a death also. Usually the episodes are self-limiting, and it will be terminating spontaneously in 10 to 15-20 minutes. Now, peak incidence of the cyanotic spells you will see between 2 to 6 months. It is rarely before the first month of life or after the 2 years of life. 40% spells are because of 40% of cyanotic patients may develop spell. Usually it is precipitated by the crying, when the child is crying severely, or feeding, taking feeds, straining on the bowel movements, and typically after getting up from the deep sleep, tries to cry, and then the oxygen requirement is increased, and they may get into the spell, especially when they are dehydrated after an overnight sleep. Now, there are some mechanisms which has explained how this exact which theory is perfect, which most of the theory commit the same, but the mechanism by different theories are different. There is a Wood theory which suggests the right ventricular infundibular spasm, the right ventricular outflow tract infundibular goes into the spasm, and this is because of the release of endogenous catecholamines, which basically the same. There is a decrease in pulmonary blood flow secondary to infundibular spasm. The other theory is Morgan's theory, is increased vulnerability of the respiratory center. There is a certain increase in activity after the child is getting awake or crying. There is a decreased oxygen, increased PCO2, the carbon dioxide level increases, which stimulate the respiratory center and which causes hyperapnea. So, these are the two important theories which one should know at the time of exam that what these people explain, these theory explain about the mechanism of the spell. Now, during spell, because there is hardly any blood is going into the pulmonary circulation, because there is no blood is going, you may not listen any murmur, or it may be a very soft murmur, soft ejection systolic murmur. ECG may show the signs of ischemia, myocardial ischemia, and also EEG may also show the hypoxia injury. Now, these are again some measures which one can manage the spell. It is very important. Usually child once 6 or 8 months they acquire, they know how to terminate the spell. So, they learn the squatting position, knee chest position, it is a crossing of the legs, or the mother is holding the child with folding legs over the abdomen or lying supine. These are some squatting equivalents one should know, and these are frequently asked in the exam. And how does it work? How does it helps the child? So, first of all, when the squatting, there is a compression of the peripheral major arteries. So, once the major artery is compressed, there is an increase in the systemic vascular resistance. So, when the systemic vascular resistance is increased, there will be less right to left shunt. So, the shunt will be more of a left to right. In that situation, the pulmonary blood flow will increase. The other thing is that the desaturated blood which is coming from the lower extremity will be reduced, because the veins are also compressed. When the abdomen is compressed, the less desaturated blood, the abdominal organ does not consume so much of oxygen. So, the less desaturated blood will be going to the pulmonary circulation. When it goes to the pulmonary circulation and in the body, then the oxygen saturation increases, whereas when the oxygen saturation increases, the carbon dioxide saturation washed out, and respiratory center gets the adequate oxygenation, hence the spell gets terminated. So, this one should know. The medical management are the standard drugs. What is more important than one should be knowing the doses of the drug. Now, first morphine is given, 0.1, 0.2 milligram subcutaneous or intramuscular can be given. It depresses the respiratory centers, sedates, calm down, anxiety is reduced, and to a certain extent it reduces the infundibular spasm also by its vagotonic action. Humidify oxygen, the role is controversial, but there is no harm in giving oxygen, because the problem is of the perfusion, not the oxygenation. So, this is a bit controversial, but there is no harm, one can give the oxygen also. Now, other important thing is sodium bicarbonate, 1 milliequivalent per kg IV, which can be repeated after every 15 to 20 minutes. It counteracts the metabolic acidosis, decreases the respiratory center stimulation, and reduces the acidosis. So, that is how it helps to terminate the spell. The propranolol 0.01 to 0.25 milligram, average usually given 0.05 milligram per kg, slow IV. It reduces the heart rate, increases the good ventricular filling. Beta blocker also relaxes the infundibular spasms. So, this is how it helps into the termination of the spell. Now, other important thing is a phenylephrine, 0.02 milligram per kg, where it increases the systemic vascular resistance. So, it promotes it decreases the right to left shunt, and the more of the blood will be going into the pulmonary circulation, which will help in oxygenation, and that is how the spell will be terminated. Finally, if the patient is not responding to anything, the usually exam one after the other it will be asked, if the patient is not responding, what ketamine, so that fully sedated, knocked down on ventilator. So, if the patient is not responding to all the above measure, you have to sedate, paralyze, and put him on the ventilator to increase his oxygenation. And once patient is on ventilator, if he is still not improved, he should go and investigate him thoroughly. What is the cause? What is the anatomy? What is the morphology? Whether any vessel is crossing or not? Is there any additional VSG is there or not? Any MEPCAs are there or not? Once you are happy with the anatomy, whether the pulmonary arteries are confluent or not, what is the size of the pulmonary artery, whether you would like to go for emergency BT shunt, or you might like to go for central shunt, or you go for the complete correction. So, after all these measures fails, once the patient is on the ventilator, you plan for the next step, that is surgery. So, surgery, I will discuss this flow chart in very brief, but next class we will be discussing our details about the surgery. So, this is how we plan first it is elective. If it is a good anatomy in elective patient, go for total repair. If it is elective operation, the pulmonary artery anatomy is poor, branches are hypoplastic, go for shunt. That is the stage procedure. Other is an emergency situation. So, when child is in spell, having severe cyanotic spells or weight, say every center has a different policy, 3.5, 4 kg. If you are comfortable, in early surgery can be done. Anatomy is suitable, a complete repair can be done in a 3.5 or 4 kg child. But if the center or the pupil or the surgeon is not comfortable, then one can stage 3.5, 4 kg child, one can stage the operation. So, if the anatomy is good, you go for total repair. If your anatomy is poor, then you have to shunt and reassess for the complete repair. But wait, if you are comfortable, you are not comfortable in your place where you can do the complete repair in 3.5 or 4 kg child, then you go for the shunt, or in emergency right ventricular outflow tract stenting can also be done. It has its own problem because the stent lying in the right ventricular outflow tract, it's a problem when you are going for the corrective surgery. Shunt, it has its own issues, we will be discussing in our next class. So, thank you very much. We will be discussing details of the surgery in our next class. Thank you.